Assalamu alaikum students. This is going to be your concluding lecture on Plasmodium, in which we are going to discuss the diagnosis, treatment and prevention of malaria. So let's start with the diagnosis. We have been through a part of the diagnosis that was the microscopic examination. Along with the microscopic examination, we have got certain rapid diagnostic tests for the detection of malaria antigens. And these include the histidine-rich protein, Plasmodium lactate dehydrogenase, which can be pen-specific or species-specific, and the enzyme aldolase. Now, as far as histidine-rich protein is concerned, it is produced by the sexual stages and young gametocytes of Plasmodium falciparum only. So this is specific for Plasmodium falciparum. It is expressed in abundance on the surface membrane of infected red cells. HRP2 based rapid diagnostic tests permit a rapid and sensitive diagnosis of Plasmodium falciparum malaria, but the drawback is that they are not suitable for assessing the effectiveness of treatment nor for monitoring drug resistance. This is because HRP2 antigen has been shown to persist for until at least 7 days after successful treatment and has been reported still present on day 28. It remains detectable after clinical symptoms of malaria have disappeared and parasites have been cleared from the peripheral blood. So, HRP2, although is specific for Plasmodium falciparum, yes, you can use it for diagnosis, but not for monitoring the treatment. Now let's talk about the Plasmodium lactate dehydrogenase enzyme and Plasmodium aldolase enzyme. These metabolic enzymes are found in the glycolytic pathway of malaria parasites. Plasmodium LDH and aldolase are produced by asexual stages and gametocytes of all 4 human malaria species. So, these LDH and aldolase are produced by Plasmodium falciparum, vivax, ovale, and malaria. Rapid diagnostic tests have been developed with monoclonal antibodies specific for Plasmodium falciparum lactate dehydrogenase and monoclonal antibodies that are pen-specific, that is, recognizing all 4 malaria species. This enables non-falciparum infections to be distinguished from Plasmodium falciparum or mixed species infections. With the isolation of specific isomers of Plasmodium lactate dehydrogenase, species-specific enzyme-based RDTs are becoming available. Next we come to aldolase. Monoclonal antibodies produced against aldolase from Plasmodium species are pen-specific and are used with histidine-rich protein 2 in combination RDTs to detect other Plasmodium species as well as Plasmodium falciparum. So in this combined test, what is going to happen is that HRP2 is going to detect the antigen which is produced by the Plasmodium falciparum species, while aldolase antibodies directed against the enzyme aldolase will detect the this enzyme which is produced by all the four species. Endolysis pan-specific antibodies do not have the same binding sensitivity for Plasmodium falciparum as histidine-rich protein 2 and may be negative when an HRP2 capture line is positive in low parasitemia. So this is the drawback, uh, that it can give a false negative result for Plasmodium falciparum. Now this is an example of a dipstick strep malaria rapid diagnostic test. The malaria rapid diagnostic test which is shown here is the Paracheck PF dipstick, which detects Plasmodium falciparum histidine-rich protein in the whole blood. So you can see a strip. The principle of this test is immunochromatography. The principle of immunochromatography will be discussed when we have a lecture on the serological techniques. Now, as you can see, you have to dip this chromatographic strip into the blood, into whole blood from this end, and then the blood is going to travel up along the strip, and if histidine rich protein is present, then the antibodies which are bound with colloidal gold conjugate particles will combine with the antigen, and they will be immobilized on this line of test which is containing antibodies against the histidine rich protein. Now this is the control line. This is going to tell you that the test is working normally or it is properly working. So this control line should always appear. If a control line does not appear, this means your strip is not working properly. So what is going to be there on the control line? The control line is going to contain antibodies which are directed against colloidal gold particles. So the colloidal gold particles, even if the test is negative, the colloidal gold particles are going to get bound with the control line since it is containing antibodies against the colloidal gold particles, while the test line is containing antibodies against the colloidal gold conjugate with the specific antigen which you are going to test. For Plasmodium falciparum, while the lower one is showing a negative test for Plasmodium falciparum. Then we move on to the malaria card test, which detects Plasmodium falciparum antigen and an antigen that is common to all four species, including Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malaria. The test uses two antibodies, one that is specific for Plasmodium falciparum, and that is histidine-rich protein 2, and this is captured on line T1, and an antibody that is specific for antigen that is common to Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and malaria. and that is antibody against aldolase, and this is quoted on line T2. So T1 line is quoted with antibodies against histidine-rich protein 2, and these are specific for Plasmodium falciparum only, while the T2 line is impregnated with the enzyme aldolase, with antibodies against the enzyme aldolase, and this aldolase antigen is common to all the 4 Plasmodium species. So this test is going to distinguish non-Plasmodium falciparum infections from Plasmodium falciparum only or mixed species infections. Now this is the malaria card test, which detects Plasmodium falciparum antigen and an antigen that is common to all the 4 species. The test uses 2 antibodies, one that is specific for Plasmodium falciparum, which is the histidine-rich protein 2, and is impregnated along line T1, and an antibody that is specific to antigen that is common to Plasmodium, all the 4 Plasmodium species, and this is antibody directed against the enzyme aldolase, and it is impregnated along line T2. This test is going to distinguish non-Plasmodium falciparum infections from Plasmodium falciparum or mixed infections. Now let us see the results. On the extreme left, you can see a pink line appearing against control, against T1 and against T2. So this shows that the patient is suffering either from Plasmodium falciparum because the HRP2 antigen test is positive, or the patient is suffering from mixed infection because the enzyme aldolase is also coming out to be positive. Now moving on to the second test, you are seeing 2 lines. One is the control and the other one is the line which is specific for Plasmodium falciparum, and it is going to indicate the presence of histidine-rich protein 2. So the second one is showing a positive line at T1 and the control line, so this is indicative of Plasmodium falciparum malaria. Moving on to the third one is showing a positive line at the control and over the area which is, or over the line which is impregnated with the antibodies against aldolase enzyme, and this aldolase enzyme is pen specific for all the 4 species. So the third test, or the third window which you are seeing, is indicating Plasmodium vivax, ovale, malariae or mixed infections. So it could be either Plasmodium falciparum infection, Plasmodium falciparum infection mixed with Plasmodium vivax, ovale and malaria infection, or it could be only the infection which is caused by Plasmodium vivax, ovale and malaria. Since the test is not coming out positive for histidine rich protein 2. So, a definitive diagnosis of just simply Plasmodium falciparum malaria cannot be made on the basis of this type of result. And the last one is showing only the control line positive, and this is a negative result. Now, there are certain limitations of rapid diagnostic tests, as a positive RDT does not always signify malaria illness, because antigen may sometimes be detected after the infecting parasites have died following treatment, or there is a persistence of malaria gametocytes which do not cause illness. The persistence of HRP2 antigen following treatment is the commonest cause of false positive Plasmodium falciparum HRP2 based rapid diagnostic test. The presence of other substances in blood may occasionally produce a false positive result. For example, heterophile antibodies or less commonly rheumatoid factor affecting both HRP2 and enzyme based rapid diagnostic tests. The presence of parasites does not always signify clinical malaria in individuals with high immunity. There may be other causes for the fever. So the parasites may be there, but the immune system is keeping the parasites under control, and the test may come out to be positive, but this is not indicative of malaria. You have to look for other causes of fever. Now we move on to the treatment. Now, the drug of choice for acute malaria is chloroquine, provided the strains are chloroquine sensitive. Chloroquine kills the merozoites, thereby reducing the parasitemia, but does not affect the hypnozoites of Plasmodium vivax and ovale in the liver. These are killed by primaquine, which must be used to prevent relapses. Primaquine, one disadvantage which is associated with the administration of primaquine is severe hemolysis in those with glucose 6-phosphate dehydrogenase deficiency. So, testing for this enzyme should be done before the drug is given. Primaquine should not be given if the patient is G6PD deficient. In areas where chloroquine-resistant strains of Plasmodium falciparum exist, the drug of choice is malarone, which is a combination of atovaquone and proguanil. Strains of Plasmodium falciparum resistant to both chloroquine and mefloquine have emerged in some countries like Thailand. In severe cases, especially of falciparum malaria, intravenous administration of either quinidine or quinine plus another antimalarial drug such as doxycycline or clindamycin be used. Outside the United States, the artemisinin such as artesunate or artemether are widely used in combination with other antimalarial drugs. The artemisinins are inexpensive, have few side effects, and most plasmodia have not developed resistance to these drugs. Resistance to artesunate has emerged in some strains of Plasmodium falciparum in Southeast Asia, like Cambodia and Myanmar and Thailand. Now, next we move on to the prevention. So there are two aspects of prevention. One is chemoprophylaxis, which is the administration of the drugs to prevent malaria, and the second one are simple preventive measures to protect against the bite of the mosquito. So in chemo prophylaxis of malaria, you administer to the travelers traveling to areas where chloroquine resistant Plasmodium falciparum is endemic, mefloquine or doxycycline. In addition, a combination of atovaquone or proguanil in a fixed dose can also be used in place of mm, chloroquine and mefloquine. Chloroquine should be used in areas where Plasmodium falciparum is sensitive to that drug. Travelers to areas where the other three Plasmodia are found should take chloroquine starting 2 weeks before arrival in the endemic area and continuing for 6 weeks after departure. This should be followed by a 2-week course of primaquine if exposure was high. Primaquine, the advantage of primaquine is that it is going to kill hypnozoites of Plasmodium vivax and ovale. Other preventive measures include use of mosquito netting, window screens, protective clothing, and insect repellents. Remember, the mosquitoes feed from dusk to dawn, so protection is particularly important during the night. Communal protective measures are directed against reducing the mosquito population. Many insecticide sprays, such as DDT, are no longer effective because the mosquitoes have developed resistance. Drainage of stagnant water in swamps and ditches reduces the breeding areas. And the most important point is that still there is no vaccine. So, with this, we finish with the parasite Plasmodium, which belongs to the class Coccidia, and the take home message is that you have to control malaria. The WHO has rolled back the malaria eradication program because the mosquito cannot be cannot all be killed. So they are now focusing on malaria control programs. So the thing is that you have to protect yourself against malaria. Travelers going to malaria endemic areas must use chemoprophylaxis, and we should use preventive measures to reduce the population of the mosquitoes. So, with this, we conclude the lecture. If there are any queries, you can ask me. You can put the queries in the group, and I'll be more than happy to answer them. Allah Hafiz, students.